Welcome to the newborn unit of ASN 225. This particular series of videos will focus on Chapter 22, which is the physiological and behavioral adaptations that newborns must go through after they're born. Let's get started. The neonatal period is defined from birth through the first 28 days of life. There are several physiological and behavioral tasks that babies must accomplish in order to be successful, or in other words, live um, successfully outside their mama. Those are listed for you in your slides, so I'm not going to read them off to you because you guys are able to read. This looks kind of like an overwhelming list, but by and large, most babies are able to do this without any kind of difficulty at all. During this first period of reactivity, the baby's heart rate will usually go up. It can go up to as high as 160 to 180 for as long as this period of reactivity is. It usually lasts about 30 minutes after birth. Babies are usually wide awake right after they're born, looking around like, what in the world just happened to me? During this time, respirations may be slightly increased. Usually we say normal baby respirations are between 30 to 60, but these respirations may go as high as 60 to 80. It would not be unusual to hear some fine crackles, see a little bit of nasal grunting, or I'm sorry, hear a little bit of grunting, see a little bit of nasal flaring, or see any possible retractions that may be present as the baby's lungs have to absorb all the leftover amniotic fluid. These signs of respiratory distress should go away within 1 hour after birth. During this first period of reactivity, babies, again, like I've already mentioned, are very alert. They're awake. They may or may not have bowel sounds, but usually they do. Some babies may go ahead and pass their first meconium stool. It's interesting though, the nervous system is really the only system in the baby that does not undergo a massive change associated with birth. Pretty much every other body system undergoes massive changes after birth except the nervous system. Baby behavior is going to be influenced by sleep and alert states, environmental stimuli, chemical imbalances such as hypoglycemia, hydration, overall health, and recovery from the birth process. I also want you guys to know that all babies have sensory capabilities at birth, including visual, hearing, taste, touch, and smell. So I told you in the last slide that when babies are in that first period of reactivity, they're very wide awake. That is a great time to help them latch onto mom and learn how to breastfeed or bottle feed. Because right after they have been awake for about 30 minutes, they are going to fall into a deep, deep, deep sleep. Their heart rates go down, respiration levels decrease as well, and they're going to sleep. They are going to be out like a light for a strong 1 to 2 hours. So if a baby has low blood sugar, if you don't feed them right after birth, it is going to be very difficult to get them to wake up to eat once they slide into this period of decreased responsiveness. So it's really important to kind of be on top of those things and make sure that babies eat right after they're born. So then we have this second period of reactivity. Again, so babies were awake, then they go to sleep for 1 to 2 hours, then they're going to wake back up again, and they'll be wide awake for anywhere from 2 to 8 hours after birth. This can last, they can be awake for as short as 10 minutes, or they can be awake for several hours, and it just kind of depends on the baby and what's going on. But basically, the baby just wakes up again, heart rate, respiratory rates increase just slightly, not a lot. They have some increased muscle tone. They're going to kick around a little bit. They usually wake up hungry again. They may want to eat. Their respiratory and gastric mucus production increases as well. This leads babies to be choke, gag, and puke. Remember, babies end up with a lot of birth goo, as I call it, in their lungs and down in their tummy after they're born. And birth goo just doesn't set well in their tummy. So this is, they start eating and then they start gagging, they start choking, they'll spit up, and it's just mucus and birth goo and stuff left over from being born. So it's important to teach parents how to use their bulb syringe in case their baby needs it. Make sure it's handy at the bedside because by then the babies are usually out in the room with the mom again. Make sure, that, and if you're taking care of a C-section mom, make sure that she has everything she needs right there at the bedside, or at least that there's another adult in there in the room with her. Because if the baby starts choking and she is still numb with an IV pump and an epidural in, she's obviously can't, get up and run across the room to save her baby. So make sure that there's always another responsible grown-up in the room with the baby. It's also important to note that the GI tract sometimes becomes active. Um, Again, babies should start stooling, possibly have their first void, um, and the baby's going to start to, they'll suck on your finger, they'll suck on a pacifier, they'll suck on the bottle. Hopefully, they breastfeed well, um, but they're much more interested in eating at this point. By 20 to 24 weeks, alveolar ducts start to appear. By 24 to 28 weeks, you get primitive alveoli appear in the lungs. By that time, alveolar epithelial cells begin to differentiate into either type 1 cells, which you need for gas exchange, or type 2 cells that make and store surfactant. From 28 to 32 weeks, some surfactant is produced in the lungs. By 35 weeks, that is when babies should have the full surfactant producing ability. So if you think about it, you think about your premature babies. Some of these babies are born by 24 weeks. Usually the typical age of viability is 23 to 24 weeks. If babies are born before that, certainly before 20 weeks, but sometimes even, 22 or 23 weeks, they may not even have alveoli present for gas exchange. And that's what makes those babies incompatible with life when they're born just too soon. Lots of times premature babies are born between 24 to 28 weeks, and the alveoli that they have, they are primitive, and I stress primitive. They're not grade A top choice alveoli. They are primitive, barely there, barely functioning alveoli. And they're not going to make surfactant at that age either. And then by 28 to 32 weeks, again, common ages for preemies, you have some surfactant ability. So these are your babies who may end up getting intubated and get like 1 dose of surfactant before they are extubated, or they may go ahead and give them a full 2 doses. But again, I just want to go back and stress 35 weeks. We really need moms to bake their babies until at least 35 weeks because that's when babies should have their full surfactant producing ability. And I say should because there's a lot of things that vary on that. If mom is unsure on dates, kind of depends on mom's nutrition, it kind of depends on a lot of different things. But 35, 36 weeks, we really need babies to stay inside and cook so they get that full surfactant producing ability. As you may or may not know, surfactant is like the greatest invention ever. It's there is artificial surfactant that has been created as one of the top advancements for neonatal medicine, like in the whole history of neonatal medicine. It has been an absolute game changer as far as being able to save babies. Surfactant is basically lubrication for the alveoli. It basically reduces the surface tension and takes to keep the alveoli open with inspiration. It keeps it from collapsing completely upon collapsing completely upon exhaling. So if you think about it, it's kind of like a balloon. If you take a lot of energy for a brand new balloon to blow it up, and then if you completely deflate it, it takes a bunch of energy again. But basically what alveoli does is when you blow up the balloon, instead of letting the balloon go all the way back down and be deflated, it keeps it where it's already been kind of stretched out, and so it inflates easier the next time. And the more times you inflate and deflate a balloon, the easier it gets to inflate. That's what surfactant does, basically. Fetal breathing movements begin at 17 to 20 weeks. It's very important to develop chest wall muscles and the overall muscle strength of the diaphragm because that helps with the regulation of the lung fluid volume, which of course is going to affect lung growth. In utero, babies get their oxygen from the placenta. Their lungs are not the source for gas exchange. That's why core compression is such a big deal. In utero, blood is shunted away from the lungs via the PDA, and we'll talk more about that in a minute. And there is no single trigger for the initiation of respirations in a newborn. And that's a good thing. That means that if one mechanism fails, we have backups. Production of lung fluid decreases 24 to 36 hours before spontaneous labor. That is a good thing. That also helps babies, well, it helps lower it decreases the risk of having respiratory distress after they're born. About 50 to 80 mLs of fluid will remain in the lung passageways of a full-term newborn. But at birth, when they gasp and they exhale, that initiates the removal of that fluid. The other thing that's important to note is during labor, babies experience a glucocorticoid and catecholamine surge that helps promote that fluid clearance, that 50 to 80 mLs that are in the lung passageways, helps promote that to go away. So which babies are the ones that are not going to get that catecholamine surge? You got it. It's your inductions, your scheduled C-sections and your scheduled vag inductions. Those babies who, when the moms come in cold, completely not in labor, they are going to be at higher risk of developing some kind of, their babies are going to have a higher risk of developing some kind of respiratory distress, such as TTN, after birth. The first breath. I bet you guys had no idea that so much stuff went into breathing, at least for a newborn, but it really does. So, what are some of the factors that affect this very first breath that a baby takes? Well, the alveolar surface tension is one, because we need surfactant there to prevent the alveoli from completely collapsing in between breaths, because it's just too hard to constantly reinflate your alveoli from being completely deflated. It's easier if those alveoli are lubricated with surfactant. The viscosity of the lung fluid, um, that is going to affect the first breath. That is something that can be influenced by the surfactant levels, but it also can be affected by meconium. If a baby has stooled in utero and passed meconium, then they're going, and if they are doing practice fetal breathing movements, which they should be doing if they are term, then they're going to inhale poop and get poop in the lungs. That changes the viscosity of the lung fluid. That's going to make their work of breathing much, much harder. Poop in the lungs is never, ever, ever a good thing. Lung compliance, again, this kind of goes back to that need that we have for surfactant. So the first breath, lungs have to expand. We get an increase in the pulmonary circulation. Hopefully, with each breath, the alveoli are going to pop open a little bit more and more and more. And then that remaining lung fluid that's in there is usually absorbed within 2 to 24 hours after birth. Why are there problems absorbing the fluid? Well, we talked about that glucocorticoid and catecholamine surge on the last slide. So that may be something. But sometimes the lymphatic system in a baby can be pretty underdeveloped. And babies can have complications and not be able to decrease their pulmonary vascular resistance, which will cause decreased pulmonary blood flow. Examples of this would include inadequate compression of the chest wall for gestational age babies or very low birth weight babies. So now you're talking about your tiny babies, your 1, 2, 3, 4 pounders. Most of the time a 5-pound baby is not, they may be small, but they're not going to be like classified as like very low birth weight or anything. But those babies, they're not going to get, because they are so small, they're not squeezed from mom on the way out, so they don't get adequate chest wall compression. C-section babies, they often do not get adequate chest wall compression. And then any baby that is having respiratory depression due to maternal anesthesia, if they can't put if they have to knock mom out with a general anesthesia instead of a spinal for her C-section, they try and get the baby out as soon as possible because the general anesthesia will cross over to baby, and then those babies are not going to be the baby's anesthetized too, and they're not real eager to breathe after they're born. You also worry about that with your moms who have been on mag sulfate. So all your moms with preeclampsia or eclampsia, the higher mom's mag level goes, it transfers over to baby too, and baby is getting mag too. So sometimes babies have to go to the NICU and be observed for a couple of hours, or 12 hours or 24 hours until that mag level comes down, and they're a little bit more excited to breathe on their own. Depending on if mom received pain medicine during labor, Stadol will sometimes cause respiratory depression in babies. Aspiration of amniotic fluid, blood or meconium. And the blood and meconium can also be present in the amniotic fluid. So when babies aspirate that and they draw that down into their lungs, that changes things and can make it harder for them to breathe. Hopefully, though, lung expansion pushes the remaining fluid into the interstitial tissue, where then it's drawn into the lung capillaries and then drains out through the lymphatic tissue. So, labor contractions cause brief periods of decreased uterine blood flow, which is going to cause decreased placental gas exchange. Now, the baby recovers between contractions, but that kind of sets the stage for the for something that goes on inside the baby as this progressive decline in the PO2 and a rise in the CO2 and a lowered blood pH. This whole setup stimulates the respiratory center and the medulla of the baby's brain. The other thing is the abrupt cutoff of the prostaglandins when the cord is severed. Prostaglandins keep the PDA open while the baby's in utero, and it partially helps to suppress respirations as well. When that cord is clamped, the prostaglandin levels begin to fall, and that is another initiation factor that tells the baby to start breathing. It's go time. So some of the mechanical factors that play into this, I've already kind of talked to you guys about babies, how it's important for them to get the nice big squeeze from mom on the way out. Um, but when they do get that big squeeze from mom, when that is released, that leaves negative intrathoracic pressure. That negative pressure helps draw air into the lungs. Crying, which is why we want babies to cry after they're born, that also helps with the air distribution in the lungs. It just basically helps fill up the lungs with air, and that is going to also be helpful to promote alveoli expansion. Crying creates positive pressure, which helps keep your alveoli open. The squeeze, the squeeze really doesn't do much to get the fluid out. It's just more for the pressure to draw the air in. So think about this. Think about how nice it feels when you're laying in your warm bed on those chilly winter mornings, and then somebody comes in and they pull the covers off of you. It definitely wakes you up. It definitely stimulates you to either jump out of bed or reach for covers again or smack the person who just did that to you. But thermal factors also affect babies in a very similar way. They go from being a balmy, 98, 99 degrees in their mom to coming out into a room. And I'm sure you guys have probably noticed, but labor and delivery rooms are not usually super warm because laboring moms are hot. It's a lot of work. It's like working out. Nobody wants, with the exception of hot yoga, most people do not work out in a hot environment. You want it to be cold. So laboring moms, it's no different. Um, However, when babies are born, when they go from that, 98, 99-degree temperature of mom to say even a 70-degree room, that is a significant temperature drop that the chilling that the baby experiences stimulates the little free naked nerve endings on the baby's skin and the newborn responds with rhythmic respirations. Now, one of the best things you can do for a baby is crank up the temp in mom's room when she starts pushing. That is really that is a hard time for mom. And if moms want their labor room to be an icebox up until pushing, I am fine with that. But as a baby nurse and as a baby advocate, I'm going to go over there. I'm going to crank that room up to at least 70 or 75 when that mom starts pushing. Um, and the reason is because we don't want to create cold stress for the baby. We want it to be warm. Um, Trust me, 75 is still going to be cool enough to stimulate those nerve endings in the baby, but hopefully that won't cause cold stress. Now, is mom and the rest of the delivery team going to be hot because of this? You bet. Are people going to be saying, wow, it's really hot in here? Because it is. You've got bright lights, people have all their personal protective equipment on, you have a lot of bodies in the room creating heat. There's a lot of heat there. Um, but you also don't want to avoid you're trying to avoid cold stress. So be an advocate for the mom and baby. Explain to them why it's important to turn the temperature up because you're trying to avoid cold stress in the baby. Cold stress is a reason why babies end up in the NICU, and no mother ever wants her baby to go to the NICU ever. Nobody ever wants to be separated. So when you say, I'm doing this so your baby can avoid to stay in the NICU, most moms will be like, crank it up. 80 it is. 80 may be too hot, but 75 is great. Um, Honestly, just with some good patient education, though, if you explain to mothers why you are doing that, and that it's there, you're turning the temperature up in the room to protect the baby, moms will be fine with it. They'll suck it up. So, welcome to the world, kid. Before birth, the baby is in this totally zen place. It's dark, sounds are muffled, the baby is nearly weightless. Close your eyes. I'm sure you all can imagine being warm and cozy in your bed, your house is quiet, then all of a sudden your covers are ripped off and you're thrust outside when it's 32 degrees with snow on the ground. It's bright, cold, wet outside, and then someone is with some nasty smelling latex glove is manhandling you and starts to suction your mouth and nose, and it smells weird, and there's that weird smell of just birth and alcohol and hospital. It's loud compared to where you were when you were sleeping, and you aren't really awake yet because it just happened, so you were in that sleepy, confused state. Every single sense is stimulated at the same time. Birth. You would cry too if it happened to you. So it's important to know that normal newborn respirations are 30 to 60 a minute. And people go, wow, that's so fast. It's not, it's fine. And we'll get back to why they breathe faster in a little bit. And you should also know that babies are nose breathers. They are nose breathers because of the high position of their epiglottis and position of their soft palate. If their nose is occluded, they can't breathe well. So you have to keep their little noses sucked out. If they can't, um, they don't, babies don't get that they can just open their mouth to breathe until they're about 3 weeks of age. Babies can pause their breathing for up to 20 seconds, and that's called periodic breathing. If a baby pauses their breathing for over 20 seconds, then it turns into apnea. Periodic breathing usually occurs while babies are sleeping. If babies are breathing less than 30 or greater than 60 at rest, then that is a reason why you should call the pediatrician or call the NICU for a consult. Any apnea needs to be reported immediately to the physician as well. Again, apnea is stopping breathing for greater than 20 seconds. Breathing is mostly generated from the diaphragm, so abdominal breathing is completely normal. If you watch babies, they are very much belly breathers. It's their whole entire belly that goes up and down. And the reason is because they don't have strong intercostal muscles yet. Between their ribs, they don't have those strong muscles to breathe yet because they're new at this. They just really started having to do this. Cyanosis of the hands and feet, that's called acrocyanosis, is normal. And even a little bit of duskiness all over while crying is not abnormal at this age either. However, if the lips and the mucous membranes start to turn blue, then that is evidence of central cyanosis, and that is not normal. That would be a reason to call the pediatrician. Central cyanosis can be caused from inadequate delivery of oxygen to the alveoli, poor lung perfusion, or cardiac dysfunction. All of those things are reasons to call the doctor. Central cyanosis is a late sign of distress, so by the time you notice that, there has already been significant hypoxemia going on. Transient tachypnea of the newborn. Most people just call this TTN. Basically, what happens is the infant's going to breathe normally at birth, but within 1 to 2 hours of age, they start getting tachypnic, and they will go over that 60 breaths per minute limit that we have set, basically. They may have a little bit of grunting. They may do some nasal flaring. They may have some mild retractions when they breathe. Um, Usually the cause of this is just excess fluid in the lungs. Remember, I told you that 50 to 80 mils remain in the lungs, um, and slowly as babies, as their alveoli expand, the fluid gets pushed off to the interstitial spaces for absorption through the lymphatic system. Sometimes that process just takes a little bit of time, and it doesn't happen as fast for all babies as it does for some. Usually, TTN will resolve itself within about 4 hours after birth. In the meantime, while you're waiting for that to resolve, some of the nursing care you may have to perform is put an oxy hood on the baby. If you look at the picture on the slide, that baby is in an oxy hood. It's like a big clear bubble. It just goes over, you stick their whole head and like, usually head and shoulders up inside there. But it just gives them like a extra oxygenated cloud of extra oxygenated air. So instead of breathing room air in that little space all around their head, they can breathe, a 30%, 30% is that's a pretty standard, oxy hood. You can also have a respiratory therapist come and do some CPT for some retained fluid. That usually works beautifully as well. CPT, they just have their little percussor and they pick the babies up and they pound on their back with a little pink and blue percussor, and that helps kind of break up some secretions, and it helps facilitate that lung drainage or that fluid drainage out of the lungs. Usually a couple episodes of CPT and some oxyhood and TTN will clear right up. The part that makes it tricky is that clinically the symptoms of TTN closely resemble respiratory distress syndrome. When you shoot an x-ray, it's going to look just like pneumonia, and so it's kind of a hard call. Is it pneumonia or is it just TTN? TTN is a little bit more common in cesarean births because, again, babies don't get that big squeeze when they're born. In babies with severe respiratory distress, heart rates can exceed 120. So that is a lot. The other thing to remember is if you're taking care of a baby with TTN, you are not going to feed them. Because if they are breathing 100 times a minute, the risk of aspiration is just too great. And so if they have to have food, and they will, because if you don't feed them, their blood sugar will go down. Usually you're going to drop an NG tube or like a OG tube, and you will tube feed them. Or you can start an IV and just give them some D10 to maintain their blood sugar. All right, the big five. These are the big five changes that have to occur from a cardiovascular standpoint for babies right after they're born. And you can read through those, but those are the big five. So before we kind of jump to that, let's jump back to how fetal circulation works. Basically, you have the mother's uterine arteries. They perfuse the placenta, where the oxygen is carried to the baby via the umbilical vein. That throws people off because we're used to veins carrying blood back to the heart. This time, the umbilical vein carries the blood to the baby. The blood enters the baby via the big umbilical vein, and it's a big red vein. It is red blood because it was just oxygenated by the placenta. Part of the blood takes the first exit, and it's going to perfuse the liver, and then the rest of the blood is going to continue to the heart via the ductus venosus. This oxygenated blood is mixed with low oxygenated blood returning from the baby's legs via the inferior vena cava, and then it continues up to the right atrium. Then the blood is dumped into the right atrium. Most of the blood dumped into the right atrium flows straight over to the left atrium through something called the foramen ovale, thus bypassing pulmonary circulation. There is a little bit of mixing of unoxygenated blood returning from the lungs, but not much. Then it goes down into the left ventricle and is pumped out through the aorta, perfusing the heart, the head, the neck, and the arms. Deoxygenated blood returning from the head and arms enters through the right atrium, and then it goes down to the right ventricle, and then it's pumped behind the heart into the pulmonary artery. Now, in utero, because of the increased pulmonary resistance, it flows from the pulmonary artery through the ductus arteriosus to the aorta and out through the rest of the circulation. See how it just completely bypassed the lungs? This blood is not as rich in oxygen, and so it is sent to the belly and the legs through the internal iliac arteries, where the umbilical arteries will direct it back through the cord to the placenta for gas exchange. And then it will re-enter the placenta where the CO2 and other waste will be filtered out, and then the mom takes care of the disposal of that. Pressure in both atria are equal before birth. However, when a baby takes that first breath, that decrease in the resistance from the pulmonary vasculature raises the pressure in the left atrium, which closes the foramen ovale. The increase in oxygenation concentration in the blood and the cord between the blood and the cord clamping causes a drop in the prostaglandins, which tells the ductus to close. The closure of these two windows completes the circuitry and thus pretty much converts the baby over to regular, non-fetal circulation, or I say adult circulation. The open ductus prevents blood perfusion to the lungs. We talked about that already. It stays open under hypoxic conditions and prematurity. But when babies breathe, they take in oxygen and they thus raise their oxygen levels, and then that tells it to close. When it closes, blood will go to the lungs and will get perfusion to the lungs, which is a good thing, right? If you're extrauterine. It's the onset of respirations that stimulates all these cardiovascular changes. As air enters the lungs, the PO2 rises in the alveoli, which is what's supposed to happen. That causes the relaxation of the pulmonary arteries, which is good. That leads to a decrease in your pulmonary vascular resistance. That means that blood should start flowing to the lungs at 100% normal blood flow by within 24 hours of age. This is crucial, absolutely crucial for the conversion from fetal circulation to just regular newborn circulation. The heart has to be able to deliver blood to the lungs for adequate oxygenation to occur. Now, shunting of blood is common in the early newborn period. You can get right to left shunting through the PDA, but if that happens, that really does divert quite a bit of blood away from the lungs. And that, how much it diverts away from the lungs depends on pressure changes related to crying, respirations, and the whole cardiac cycle. This is partly what makes babies so unstable during this transition period. For the first 2 hours or so of a baby's life, they really are pretty unstable. And thankfully, I guess, most new parents are blissfully unaware that all of this stuff is going on. Once you increase the aortic pressure, um, you'll have decreased venous pressure. That occurs when we clamp the cord. You cut off the placental vascular bed, which will reduce the intravascular space. Blood return from the inferior vena cava decreases. It causes a decrease in your right atrial pressure and a small decrease in pressure in venous circulation. The increased systemic pressure and decreased pulmonary pressure, this combo decreases your pulmonary artery resistance. If you think of it, this is kind of like Black Friday shopping. People are lined up at the door, they're waiting. That's your pulmonary vascular resistance, the locked doors. Suddenly, it's time for the store to open and the doors are unlocked and people go rushing in. That's when the pulmonary vascular resistance drops and the blood rushes over to the lungs. Does that help explain it? I am full of crazy analogies like this, so I hope you enjoy them because there's probably a whole lot more coming your way. Hopefully, the PFO closes shortly after birth. It should close within 1 to 2 hours after birth. Um, but it's not completely sealed. The door is not locked. So if a baby cries a lot, sometimes crying can open the PFO back up temporarily, not completely, but it's kind of like if you have a door and you close it, but you don't lock it, but then somebody comes and, the wind can like push a door open a little bit. That can happen. If the PFO reopens, it can lead to a little bit of mild cyanosis, and I stress mild. Um, so I mentioned crying is a reason why the PFO can blow back open. Cold stress, so if babies get too cold after birth, their PFO is going to blow back open. Acidosis can also cause the PFO to stay open or to reopen. Full anatomical closure of this should occur by 30 months of age. If it does not completely close, the PFO can be a contributing factor to strokes later in life when people throw a blood clot. And that's actually, that's kind of it's kind of a cool thing when they can trace it back and say, people have, especially young people have a stroke, and then they do an echo and then they see that they have an open PFO that never fully closed as an infant. And they can trace that back and say that is the reason why they had a stroke. So the closing of the PDA. The placenta supplies prostaglandin, which tells the ductus, the PDA, to vasodilate. If the lungs fail to expand after birth, or if the PO2 levels drop, the ductus stays open. When does this happen? When you are born early. Because if your lungs fail to expand because you don't really have alveoli, or because your alveoli are primitive, it may not be enough to tell the ductus to close, so it will stay open. Or, it's same thing, if you don't have good oxygenation because you don't even have, proper alveoli, that is another reason why that tells the ductus to stay open. We see this all the time in preemie babies. Once the PDA closes, it becomes a ligament. Hypoxia, which I just talked about, asphyxia, and prematurity all can cause delayed closure of the PDA. And just like the PFO, the PDA can close, but if the baby goes back into hypoxic conditions, then that can cause the PDA to blow open again. You can hear a PDA murmur. Some people say you can hear a PFO murmur too, but some of these, open valves, the PFO and the PDA can be, they are an audible heart murmur if you can auscultate and listen to it, if you know what you're listening for. You can hear them. And just in case you were ever wondering what happens to the umbilical cord vessels, those rapidly constrict and shrink up within minutes after birth and become ligaments over the course of 2 to 3 months. So the closing of the ductus venosus, this is the last thing. This is thought to be the result of mechanical pressure changes after cutting the cord and redistributing the blood and all the changes in cardiac output. You get full closure of this within 2 months. And if you don't like the way I've explained things, or if it is, clear as mud, there is a table in your book, table 22.4, and it kind of goes over, it's a summary of all these cardiovascular changes. Feel free to review it. In fact, you should review it even if you actually listen to this video, because tables are good. It's a good way to summarize a lot of information. And that concludes the end of this part 1 of chapter 22, because that is a lot to learn. Who knew that actually being born and taking that first breath would be so darn complicated? But it really is. So I hope you enjoyed the video and got something out of it. Have a great day.